Hi everyone, welcome to POC Nurse. In this video, we're going to talk about pneumonia for the Ccrn exam. What is pneumonia? It's an inflammatory process and it affects the terminal airways and the alveoli of the lung. It's caused by an infectious agent that could be anything from bacterial to viral. So with pneumonia, there's accumulation of fluid in the alveoli due to this inflammatory process. There are two types of pneumonia, and there are different organisms that can cause pneumonia. So pneumonia can be caused by bacteria, it can be caused by viruses, fungi, or parasites. The two types of pneumonia are community-acquired pneumonia, which happens outside of the hospital, and some common pathogens that cause this are Streptococcus pneumoniae, Klebsiella pneumoniae, Haemophilus influenzae, to name a few. The second type of pneumonia is hospital-acquired pneumonia, which happens in the hospital. It could happen in a nursing home, in a long-term care facility, or in an acute care facility. Under hospital-acquired pneumonia, we also have ventilator-associated pneumonia, which is also called ventilator-associated event. This happens after the patient has been admitted for 48 hours or more to the hospital. And hospital-acquired pneumonia has a higher mortality rate than community-acquired pneumonia. So it's important to know about the ventilator-associated pneumonia for the Ccrn exam. It is now referred to as ventilator-associated event. So if on the exam you see them saying something about a ventilator-associated event, it's the same thing as ventilator-associated pneumonia. So if a patient is admitted, is intubated, and the patient gets pneumonia after 48 hours, it would most likely be attributed to ventilator-associated pneumonia. Moving on, what are some risk factors for pneumonia? There are several factors. It includes age, if the patient has a pre-existing pulmonary disease, if the patient is a smoker, if we have decreased level of consciousness in the patient, if the patient has an artificial airway, we just talked about ventilator-associated pneumonia, if the patient has any chronic illnesses, if the patient is malnourished, immunocompromised patients at high risk for developing pneumonia, if the patient already has atelectasis, that means the patient's alveoli are collapsed, if the patient has a depressed cough or gag reflex, they cannot clear their airway. If the patient is taking a lot of antibiotics, that's on concurrent antibiotic therapy. If the patient has aspirated, because there is such a thing as aspiration pneumonia. If the patient, for example, has an infection in one side of the body, it can spread to the lungs to cause pneumonia. So a patient that has an infection in one place is also at risk for developing pneumonia. And patients that have multiple organ dysfunction syndrome are also at risk for developing pneumonia. What are some signs and symptoms of pneumonia? First of all, the patient might be tachypneic. Patient might be breathing fast. Patient may be tachycardic, could complain of chest pain, because remember, the lungs are in the chest and this inflammatory process is happening in the chest. Patient may have fever, chills, patient may be diaphoretic, patient might complain of malaise, I just don't feel well, everything hurts. Patient may be confused, especially if it's the older people. The elderly have a different reaction to infection. They might get confused, have a declining level of consciousness. If the patient has a productive cough, which is part of our respiratory assessment, we ask the patient, do you have a cough? Is it productive? Is it dry? Is it wet? Meaning you can hear some phlegm in there, but the patient is not coughing up anything. Is the patient breathing with accessory muscles? These are some of the signs that you could see in a patient with pneumonia. They might use their accessory muscles to breathe. Patient may complain of dehydration or may be dehydrated. And when you do your assessment of the lungs, right, there is increased tactile fermenters because you have fluid sitting in the alveoli. When you tap on the chest, it's going to feel like a drum. It'll be dull to percussion. It's going to feel like, I don't know how else to explain it, but it will be dull to percussion. You will have diminished breath sounds or bronchial breath sounds. You have bronchophony, sounds are louder and clearer. Egophony, whispered petriloquy. I hope I said that right. That is, you hear whisper as well. It just goes to say that, at least through my understanding, sound travels better through objects than through air. So if you have a patient with pneumonia and this patient has fluid sitting in their alveoli, right, it'll be easier to transmit sound through this person's chest. So if you put your stethoscope on the person and they say something, you're likely to hear it clearer than if their chest was just full of air and no liquid. Is basically what I understand from the the egophony, whispered petriloquy, and all of that stuff. Sound travels better in a patient. Sound in the lungs travels better in a patient whose lungs are occupied by anything solid, such as fluid. Hope that makes sense. Moving on, we're going to talk about diagnostic tools in pneumonia. I think the number one tool is a chest X-ray. Because when a patient comes in, complains of anything in the chest, well, chest pain, first you do your EKG. The next thing you can do, if the EKG turns out normal, you can do a chest X-ray to see what's going on in the patient's chest. Most of the patients have gotten the pneumonia is usually once they do chest X-ray, chest CT, the report could say that the findings are consistent with pneumonia. So chest X-ray. On the chest X-ray, it will say consolidation or diffuse infiltrates. You can do a sputum culture to tell you what kind of organism is causing this pneumonia. We can do blood cultures. We can do a CBC to check the patient's white blood cells. You can do a ABG to check for how well oxygenated the patient is. Is there any hypoxemia going on? Is the patient's PO2 greater than 60 or less than 60? You can also do a thoracentesis for effusions to get the effusions, the fluid out of the patient. That is talking about diagnosis of pneumonia and the diagnostic tools that we can use. How can we treat pneumonia? Well, it's a disease that affects the lungs. When the lungs get affected, oxygenation gets affected. So we want to make sure this patient is properly ventilated and the patient is oxygenating well. So you could give the patient oxygen if the patient is still awake or oriented. You could give them oxygen, titrate the oxygen so that you get at least O2 stat that's over 90%. If you're titrating FiO2, you want to titrate it so that the PaO2 can be over 60 millimeters of mercury. We talked about positioning in respiratory failure in another video. We can use positioning in the patients that have pneumonia. So let's say this patient, only one lung is affected with pneumonia. Then you want to put the good lung down so it gets better perfused by gravity and the patient will be better oxygenated. So with positioning, you can put the good lung down. We can give the patient chest PT, do bronchial hygiene, try to get those secretions mobile and moving. We can do this by turning the patient side to side. I've had a patient on one of those proning beds where you turn the patient. Those are cool. The patient can have non-invasive ventilation, or the patient can be intubated if needed. The patient can have a bronchoscopy with lavage if needed, and we, like I said before, mobilize the patient's secretions so that they are easier to clear. You can do that by moving the patient. Chest PT is also good. Treatment of pneumonia also includes identifying the organism so that we can treat appropriately. So if we know what family of bacteria is causing it, we can target it with the appropriate antibiotics. Antibiotic therapy. When we talk about antibiotic therapy, we talk about empiric therapy, timing, organism-specific therapy, as soon as the cultures come back. So when we talk about empiric therapy, we base the antibiotic we choose on what the likely organism that's causing this pneumonia is and whether that organism could be resistant to antibiotic therapy. Timing of the antibiotic therapy. We want to give the patient the first dose of antibiotic within 4 hours of the person presenting to the emergency department. So that means the first dose of antibiotic should be given in the ER. Now, this protocol is different from this antibiotic timing protocol for pneumonia is different from if the patient is septic or if the patient has sepsis. Now, we talked about organism-specific therapy. So you can't do anything about this until obviously you get the cultures back, know what organism is causing the pneumonia, and then target that organism specifically with known antibiotics that will kill it. Continuing on with treatment of pneumonia, we also want to provide support to the patient's body by providing hydration, keeping the patient hydrated, of course managing the patient's fevers if any. We want to keep the patient's temperature down. We want to keep the patient's blood glucose tightly under control, and we also want to provide nutrition. General preventive measures are also necessary in treating pneumonia, because if you try to prevent it and not get it in the first place, there will be no need for treatment. That's why, remember, when we admit patients to the hospital, we always ask, have you had the pneumonia vaccine, and offer it to those who are 65 and older and some other people that qualify, like people with chronic diseases. We want to advise smoking cessation, and we also want to encourage the patients to get the flu vaccine if they are open to it. Some patients are not, but we should offer it as it could help, keep them from getting pneumonia. Now, how do we prevent hospital-acquired pneumonia? Well, we as healthcare providers could wash our hands. That's the first thing we always do, practice hand hygiene. So that question always comes out on the Ccrn exam. They'll say something, what's the best way to prevent infection? Hand washing. Washing our hands. And then the next thing, of course, is keeping the patient's head of bed elevated at 30 degrees or later. This is part of using positioning to treat the patient in any kind of respiratory distress. Also, we want to prevent bacteria from going from the patient's GI tract to the patient's lungs. So use the patient's gut, meaning feed the patient. Start tube feeds. If the patient's able to eat, feed the patient. We want to practice oral hygiene for the patient. So especially patients that have vented, where we do oral care, we do mouth care on these patients with the chlorhexidine to try to prevent ventilator-associated pneumonia or ventilator-associated event. Now, for the patients that are being fed through a tube, the patients with a feeding tube, an NG tube or an OG tube, we want to make sure that the tube is in the right place prior to starting feeds, because if it's in the lungs and we start the tube feeds, we're making the patient's situation worse. Now we're introducing those tube feeds into alveoli that are already filled with fluid. We're adding more fluid. It will make the patient's situation worse. But as far as I know, before an NG tube is used, you need an OK to use. That OK to use can only be given if an X-ray has been done, the doctor has read the X-ray and seen that the NG tube or OG tube is actually in the stomach. After you get your OK to use, you want to mark the exit site of the NG tube. That is, wherever the NG tube stops at the patient's nares or on the patient's lips, you want to mark it so that if it migrates in or out, you know that this NG tube, this OG tube has moved and may no longer be in the stomach. So you need to let the doctor know. They need to do another X-ray, and you need another OK to use before you continue to use this OG tube. I had a patient one time, I don't know what happened, but his OG tube was not secure. So I see this OG tube, it's come out so much. So I had to tell the doctor. We put another OG tube, another X-ray, another OK to use before I started feeding the patient again. So it's important to know when your tube has migrated. The only way to know is if you mark the exit site, so that when it migrates, you can note to ask for another x-ray or ask for another tube to be inserted. All right. You want to assess the patency of your OG or NG tube every 4 hours. And in some hospitals, chest x-rays are done every day, every morning. At one hospital I worked, every morning the patient got an ABG if they were vented and a chest x-ray, and that chest x-ray would check for placement of the ET tube. If the patient had an NG tube, the NG tube position was also confirmed. So you want to review these x-rays to make sure that the NG tube is still in place, or that if there's anything wrong with the NG tube, that you are aware. And we already talked about marking the exit site, so that way if the tube migrates in or out, you will know. And you also want to obtain an x-ray if you doubt that the tube is not in the right position, that it has moved. Just get an x-ray to confirm the tube's location. You want to observe the appearance of the feeding tube aspirate. That's if you interrupt the tube feeds for more than a few hours. And you can also, if you have like these pH strips that you dip in urine, if you have those, you can measure the pH of the feeding tube aspirate if you DC the tube feeds for a few hours. You also want to observe changes in volume of aspirate from the feeding tube. So you want to check your gastric residuals, make sure the patient is not retaining the tube feeds, because the patient can, if the patient's belly is full, they can aspirate on the contents of their stomach as well, and that can lead to, can make a bad situation worse. It can lead to aspiration pneumonia. How do we prevent ventilator associated pneumonia? We want to remove any accumulated fluid that's in the tubing so that it doesn't backflow into the patient's airways. We want to prevent that backflow. So you want to position all of that tubing so that even if there's fluid in it, it doesn't drain into the patient's lungs or mouth or stomach even. It just doesn't want, we just don't want it to go back into the patient. You change the ventilator tubing when it's contaminated, mobilize the patient, move the patient side to side, and use a septic technique when you're suctioning the ET tube or the patient's trach. Of course, we want to do our mouth care. We want to use the chlorhexidine to clean the patient's mouth. We want to clean the patient's mouth with or brush, because when you look in that oral care kit, there are brushes and there are those sponges. I like the two. You can use the brush to scrub things off, and you can use some of the patients don't have any teeth, so you could use the sponge to just gently clean their mouth with the chlorhexidine. The ET tube cuff needs to stay inflated. It partially protects from things seeping down into the patient's lungs. And you want to perform subglottic suctioning prior to cuff deflation. You also want to perform routine oropharyngeal suctioning on the patient. You want to suction the patient's mouth as well. This is where we're going to stop for pneumonia. I hope you found this useful, and I will see you in the next video. Please like, share, and subscribe. Bye-bye.